Welcome back to Dumbest in the Room podcast. Today I'm joined by somebody who I've been friends with for a few years, but we know each other from what she does outside of what she does professionally, which is acting. But professionally, she's a lactation consultant, and today that's what we're going to be talking about. Today I have Leah Tribus. Leah, thanks for being here.
Thanks for having me.
So this is not something, lactation consulting, not something that I talk about regularly, whereas you talk about it every single day. So for me, this is going to be a little bit more uncomfortable than talking about my last guest as a news anchor who I know. So let's first talk about how you got into nursing. I know you've been doing it for 17 years. Mm-hmm. And then let's talk about how you landed in lactation consulting.
Okay. That sounds great. So I went to James Madison University. I knew I was interested in healthcare, but not sure what. I think I switched my major 5 times. I started as a physical therapist major. Then I switched to pre-physician's assistant, 1 semester as athletic trainer, and then I moved to nursing. And I think what I finally landed on with nursing was the flexibility. I realized that it's a type of job that there's a million different ways to be a nurse, different types of nursing, and that flexibility to kind of find my way was really appealing.
Awesome. So, all right. So lactation consultant is very hyper specific. So you said you've been doing that for 12 of your 17 years.
Yes. So it is. It's pretty hyper specific. When I was in nursing school, I knew I wanted to work with moms and babies. I thought I wanted to be a labor and delivery nurse. And my first job wouldn't hire me as an L&D nurse. So they hired me as a mom baby nurse, which basically is the nurse that takes care of a mom after labor and the baby. And so I did that for a couple of years and was just ready to make a switch. And actually, I was approached by a recruiter who asked if I would be interested in lactation consulting. I had already done parts of that as part of my job already as a floor nurse, as a mom baby nurse, but not that specifically. So they approached me and just said, hey, listen, you applied for a different job, but we have an opening in this job. Would you be interested? And I said, well, I don't have a certification or anything. And the rule at a lot of hospitals are that you can work to earn your certification because you have to have so many hours to sit for the exam to become a board certified lactation consultant. And so they let you work for up to 2 years before you have to sit for the exam and pass. So I was like, okay, sure, I'll give it a whirl. I'll try it and see how I like it. And it's interesting because a huge component of what I do is education, actually, because I think with any parenting things, you don't know what you don't know. And with breastfeeding especially, you can be as prepared as possible prior to the baby being here, but until you actually breastfeed, totally different story. So I always loved teaching. I thought about education as a major, actually, when I was in school. And so the teaching component of it is something that I enjoy a lot.
Awesome. All right. So with 17 years of nursing total, have you been with the same hospital system the whole time?
No, actually. I've worked here in Hampton Roads. I've worked for four of the different hospital systems. So I've been with the one that I'm with now the longest. And
so from here, you're starting your own company, which I think is awesome. So tell me about that.
So I've been thinking about this for a while. There's always a gap between the care that you can give in the hospital and around 2-3 days, you're sending moms and babies home, just praying that they're going to be okay. And for a while now, I've floated. So I'm in the same health system, but I've floated to a outpatient pediatric clinic. And there I provide so much more help. That's kind of like the time when parents get home, they don't have any help anymore from the hospital people. So they're just guessing what to do and trying to make good choices and do the right thing. And I found that outpatient piece was so important. But even that can be limited because I can only see patients who go to that pediatrician's office. So I just started looking into it and thought, there are moms out there slipping through the cracks, and I don't want to see that happen. My goal is to be able to take insurance. I don't want moms to have to pay out of pocket. And for years, moms did have to pay out of pocket. So now finally there's some programs in place with certain healthcare laws that are providing insurance coverage for lactation care. So my ultimate goal is to take everyone's insurance. And right now I can take some insurance, and I'm working on being able to take more.
So why wouldn't an insurance company cover something like this?
So It's really interesting when it comes to insurance billing and things like that. There is so much I'm learning as I've started my own business that there are so many pieces. So it's sort of like the insurance company knows what they need you to say or bill. Like they know the code they need you to use, but they don't tell you what that is. And so there's a lot of trial and error. So you kind of go like, oh, like I'm going to try to bill it under this. And then they kick it out and say, no, sorry, like that's not the magic number. And so you kind of have to keep trying, putting different codes and working a different way to get them to cover it. The coverage is there by law. The coverage is there. It's just a matter of getting it covered. So there's some red tape for sure, but I'm working on it.
Well, good luck, because
Yeah.
there's a lot.
Yeah, it gets really, really confusing.
Yeah. Well, I'm sure you're killing it. So, okay. So let's first dive into breastfeeding. There's kind of a stigma about it.
Yeah.
So some people are for it. Some people are against it. Public, private.
Yeah.
Talk
Yeah.
about that.
So I think that it's changed. I mean, in the almost 12 years I've been doing this, things have changed a little bit. Actually, a lot. I think our rate of breastfeeding moms has gone up. It used to be sort of like a familial thing, like generational. If your mom breastfed, then she would encourage you to breastfeed your child. Or if she didn't, then it's like, just give a bottle, kind of was the mentality. And I see more and more women making their own choices when it comes to breastfeeding. I think there's a lot more information out there about breastfeeding, a lot more public knowledge, if you will. So I think it's gotten much better. And the reason why anyone even knows about like the controversialness of breastfeeding in public is because it's happening. So, I mean, I think the main thing is, our breasts are made for nourishing children. They really are made for that. That does not mean that every mom has to do it, but that's really what they're for. So I think the idea behind breastfeeding in public is sort of like, I'm feeding my baby. I'm doing something really natural. And so the law does protect moms that want to breastfeed in public. The law also protects moms that have to go to work and need time to pump. So there are a lot of good things about things becoming more public.
Yeah. You said that's what they're for. And, not in a bad way, but that is just insane to me. Like how everything works. Like,
oh yeah. I mean, I think it's like, especially when you do this and you see how our body responds to hormones and just knows what to do once the baby's born is pretty incredible. And then learning like how putting a baby to mom's chest, literally just laying a baby after birth on a mom's chest, increases the rates of breastfeeding long term is amazing. So most hospitals now absolutely will provide 1 hour of skin to skin before they even take the baby to weigh the baby or do vital signs. They'll do the vital signs at mom's chest. So they try to do a lot of things to facilitate not separating mom and baby because the benefits are so amazing.
talk about some of the benefits, because I know you did one of these with my girlfriend who's a nursing student.
Yeah.
And I kind of overheard a little bit. And the antibodies and stuff from the mom go to the baby, but I know there's more than that.
Yeah. So, I mean, obviously, I think I used to teach a breastfeeding class, and I had to use like this regimented slide. And one of the first things on there was like the bond. And I always would tell the people that took my class, like, that takes time. You're bonded to your baby because they're born, but enjoying breastfeeding isn't something that's like instantaneous. That's something that takes time because you get better at it, more comfortable. But that is something eventually that will get you there, bonding with your baby that way. And then, yes, like as you discussed, breast milk is really like a living organism. It's pretty interesting. So if you look at formula under a microscope and you look at breast milk under a microscope, the breast milk has living, moving parts, and that's immunity. It's kind of like a oral vaccine for anything that the mom has ever been sick with and built antibodies to. Ever, pretty much. Wow. Anything she still has antibodies for. So if she doesn't have the titers, what we call it, then no. But anything that she still has immunity to, she will pass to the baby. It's pretty much the only thing that you can like drink that gives you that kind of protection. So in the first 6 months of life, it's very unusual for a baby to get fever, for example. We consider it a medical emergency because the placenta gives them a lot of immunity, but then breastfeeding on top of that gives them an amazing, intact immune system. Now, that doesn't mean like run out and have everybody touch your baby, but it just gives you a lot of peace of mind knowing that while they're developing their own, you can give them that protection daily by feeding them breast milk.
One thing that's pretty timely, I don't know how prepared you are for this because I didn't prepare you for this, but with the COVID vaccine, obviously this is going to come out April 1st, and that is in a few weeks, but so things could change.
Yeah.
But has there been any research or anything about that vaccine on?
Yeah, I mean, so both with COVID, so COVID positive moms are encouraged to breastfeed. We take precautions. So those moms wear masks and they're not like, they're washing their hands and stuff when they're feeding, but their breast milk is again building up the antibodies to COVID during the infection. And so they should be feeding their babies. So in the hospital, we don't separate a COVID positive mom from her baby because we know how important that immunity is. And the baby on their own trying to fight it would be harder. So with the vaccine, the recommendation is that pregnant and breastfeeding women can and should get the vaccine. That is the recommendation from different health organizations. No one said like, we should wait. So even though they didn't do studies on pregnant women, they're encouraging everyone to get it.
And just a disclaimer, this is as of March 6th.
Yes. Yeah.
So things could change.
Yeah, for sure.
All right. So we talked about the benefits of the antibodies with breastfeeding, but there's more.
Yes. That's a big one. But we also know that babies that breastfeed have a lower rate of SIDS, certain childhood cancers, diabetes, autoimmune disease, and I believe even celiac disease. There's a lower risk of that. Let me check my source. Yes. It also decreases the risk of obesity, which is why it decreases the risk of type 2 diabetes. And then for mom, it reduces her risk of certain ovarian and breast cancers because our breasts are never really mature until we get pregnant. So it's kind of an interesting fact, but there are also studies that are showing that like women that are on birth control for, let's say, 25 years, sometimes don't have fully developed breasts because they haven't been like ovulating in a normal way. So there's a lot of interesting data when it comes to, kind of the effects of getting pregnant and having a baby. So decreased ovarian and breast cancer is a pretty awesome benefit. It can help with mom's blood pressure. It helps with depression to breastfeed. So there's a lot. I mean, the list goes on and on. It's pretty amazing how many things do it. I always think of the immune factors because I feel like for me that was always a big deal. But I think, there's a lot of really good benefits.
One thing of that really stood out to me was it helps prevent diabetes. Like, how is that? Is it setting up a child to like have the foundation, or like how does that work?
So it's pretty interesting because breastfed babies feed very differently than how in our minds we would imagine babies feed. So if you kind of break down a bottle-fed baby that's fed with bottles 24/7, they take pretty much the same amount of bottle every 3 to 4 hours, like 3 ounces every 3 to 4 hours. A breastfed baby doesn't eat like that. So just like you and I don't eat like the exact same amount of calories at breakfast, lunch, and dinner, breastfed babies get more at different times of the day. So mom's prolactin levels, which are responsible for making milk, go up during the nighttime, which usually means the early morning feed is like a big feed. So baby may get, the bulk of their calories at the first morning feed. And then every 2 to 3 hours they're going to feed after that, they're getting a varied amount of breast milk. So they learn how to regulate their hunger differently. Instead of being told how much they need to feed, they regulate it. And how they regulate it is when a baby breastfeeds, once the milk is in, the milk starts pretty slow. Mom will release oxytocin, which makes her have what we call a letdown, which is the release of milk. And when the letdown's happening, the milk's coming quickly. And so baby's like almost chugging. You'll hear a baby making like pretty quick swallowing sounds, like one suck to one swallow. And then that will happen for a certain number of minutes, and then that will slow down. If the baby's truly still hungry, they can stay at the breast. It'll slow down. They'll suckle again in a different pattern, which will then make mom have a second letdown, and they'll get another bulk of food. If they're getting full, that slow down flow kind of cues their body like, I think I'm getting full and I don't really need to stay on. So they'll either get sleepy or come off, but it helps them regulate. So when we look at toddlers down the road, if we put a formula-fed baby next to a breastfed baby, often the breastfed baby won't clean their plate because they sort of just eat until they're full and then push the food away. They also tend to be grazers. So when they start to take solids, they'll eat, kind of to hunger. They don't just like eat at mealtime. They kind of say, I'm hungry, and they eat when they're hungry, and they don't eat when they're not hungry. So it just sets you up for good habits when it comes to eating, a good relationship with food, sort of. And then, of course, the other benefits are the gut remains really intact, which kind of prevents certain childhood allergies and things like that, because we're not exposing the gut to anything that's not meant to be there. So with breast milk, it's, human milk for a human baby. So it's our body knows exactly how to utilize it and use it. And there's no inflammatory processes. As adults, there's probably a lot of you out there that, have sensitivities to certain foods. Dairy causes you some problems. Wheat or gluten causes you problems. So if you imagine, we don't ever have that usually. Sometimes if a baby has formula in the hospital and there's family history of a lactose problem, or like a milk protein allergy, that can come out if mom eats dairy. So there are rare occasions when, the breast milk isn't the best thing, but it's super, super rare. So yeah, so it's pretty interesting, just all the things that it does. I mean, there's like topic upon topic on this.
All right. So in that answer, you kind of touched upon the baby knowing when to stop. And that brings me to a listener question from Sarah in Alabama.
Yes. Okay.
Hey Leah, my name's Sarah. I'm currently 15 weeks pregnant with my second little boy. Unfortunately, with my first son, I was unable to breastfeed him. We had some complications at birth and he wasn't able to really regulate his own blood sugar, so we ended up going with formula. This time around, we really have been looking at breastfeeding. My biggest worry or concern would be just making sure that my baby is well fed and well nourished. It's easy with formula, you measure out exactly how much baby's eating, but with breastfeeding, it's not the same. So a little bit of insight on that would be great. Thank you.
So that's actually a wonderful question, and it's multi-layered. So babies, newborns do, this is kind of how I explain it to parents. They come out of the womb, they've been fed, if you will, through their umbilical cord. So they don't know how eating works. So they actually don't come out, quote, hungry. And it's actually, we use a lot of terminology even in the hospital where we're like, oh, I think your baby's hungry. It's not really accurate. It takes days and days and days for babies to build a drive to eat like we do. So that being said, in the first few days of life, it's very different than what I was describing later. In the first few days of life, we really have to convince a newborn that breastfeeding is a good idea, because honestly, they would just sleep and snuggle and never eat. And that wouldn't be good. Us as parents with big brains, we know that our babies need to eat. They don't know that yet. So in the first day of life, typically babies are pretty slow at the breast. We utilize reflexes. So, when you go to the doctor and they tap your knee a certain way, your leg kicks out. You didn't tell it to do that, right? So it's kind of odd that you can have that response. There's one in your elbow as well as an adult. We don't keep a lot of our newborn reflexes. Babies have tons of them. And babies have them because those reflexes are what get them to eat at the breast. So the way that I explain it to parents, and I think it breaks it down really well, is that your baby has a sucking receptor. And for all intensive purposes, I like to call it a button on the roof of their mouth. When we hit the button with anything, a passy, a finger, or mom's breast tissue and nipple, it makes the baby involuntarily suck, which is pretty wild. Like if you
crazy.
think about like taking a straw and putting it in your mouth and then your body just taking over and drinking what's in there. Really, really strange.
Yeah, that's insane in like a good way.
Yes, exactly. So without that protective mechanism, babies wouldn't eat basically in the first couple of days and we'd be in trouble. So there are cases where what happens is that reflex to suck is dampened for some reason. So certain times I find that babies have very heightened reflex and other times it's pretty dampened. So a heightened time is right after birth. Right after birth, babies aren't really in shock yet. They're kind of like really teachable in that moment. And usually we can get 1 to 3 good breastfeedings in the first 6 hours of life. After that, breastfeeding gets really hard. And this is where a lot of parents have missteps because they get really scared that their babies aren't, quote, hungry or interested in the breast. I have a lot of moms say to me, I feel like my baby doesn't like it. And I always say, I promise your baby doesn't have that many opinions yet, But what it really is baby does not know that they need it to live. Mm-hmm. So for them, they're just getting out of this water aqua environment. Now everything's loud, it's bright, it's very overwhelming. They have to breathe, which they never had to do before. They have to toot. They never had to do that before. So if you just think about all these like things that we're asking their body to do, when they were in the womb, every need they had was met without them ever having to ask. Now they have to fuss or do things to get what they need. And they just don't really understand how to interpret the feelings of their body. So they shut down. They tend to sleep it off. It's kind of like, I'm not sure I like it out here. I'm going to just sleep this off for a while. So first 24 hours tends to be a pretty tough time for breastfeeding. And I always warn parents about this because I'm like, look, this is going to be really hard. Baby doesn't know they need to feed. What we're going to try to do in the first day and a half of life is use their reflex to convince them that breastfeeding is a good idea. So we use conditioning, basic conditioning. I never like to compare a baby to a dog, but I use the picture of Pavlov's dog. They rang the bell, the dogs would salivate because they knew the meal was coming. So with babies, after having successful times of utilizing the sucking reflex to get baby latched on, get some good sucks, baby starts to enjoy breastfeeding. They enjoy it because when their whole other world is totally different, here's something very comforting. So they start to feed from desire to be comforted. It's still not really about food, but when we can get them to do that, we can get them fed, right? So that's really important. What I do with parents is I'm really proactive about those babies that are on blood sugar protocols, which means we're watching their blood sugar, or we have a baby who has lost a little too much weight. And in those cases, what we do is we have mom do something called hand expression. And hand expression is a really good way to get drops of colostrum out for baby. There is a really good reference that anyone listening that's going to have a baby should check out. It's Stanford University, and it's a public format, so I can say it on here. They share this information. So it's Stanford hand expression. It's a video. If you Google it, it'll come right up. And I encourage every mom to watch that so that they kind of feel comfortable doing this. And anytime in the first day and a half that your baby won't feed, we have mom hand express drops of colostrum either into a spoon and feed it to the baby, or we just open baby's mouth and put a couple drops in there. Newborns only take 5 to 7 milliliters, which is about a teaspoon and a half at each feeding. So they don't need a lot in that first day, but they do need some. So that was a really long-winded way of explaining that, yes, babies do have unknown amounts of food going in there when they're breastfed. So we watch pees, poops, and their weight. That's kind of our best way of figuring out if they're getting enough or not getting enough.
So if they're not getting enough, is that when you do the 7 milliliters, or is there like a supplement? Or
yes, so that's a good question. So we determine whether or not they're getting enough by lots of different things. Like I said, weight, pees, and poops are important. In the case like she had with low blood sugar, we have a protocol. So with that protocol, if a baby has a low blood sugar, we do something called glucose gel where I work, which we kind of rub it in the cheeks of the baby, and the baby absorbs the glucose, and we try to get the blood sugar up that way before introducing formula. If we have a repeated low blood sugar and mom is unable to hand express any drops of colostrum, then we think about introducing some formula to just get that blood sugar up. There are lots of ways we can introduce formula in a way that won't discourage a baby from breastfeeding. So every lactation consultant, I would say, has a little bit of a different philosophy about how to handle things. But generally our rule is always, number one is get the baby fed, right? Like baby's safety is our number one priority. And then number two would be keep baby interested in the breast. So if we have a mom that really wants to breastfeed, and I always cater a plan based on mom's goals. So I'm never going to push my agenda, my breastfeeding agenda on a mom. But if she really wants to do it, then we talk about how to preserve interest in the breast. And we can do that by syringe feeding the baby the formula at the breast. So baby's suckling at mom's breast while getting the formula. And this is a way we can prevent baby from getting used to the bottle.
Interesting.
Yeah.
All right. So where Sarah was not able to breastfeed, that is a common thing.
Yes.
And it's just as fine as somebody who can.
Yeah. So this is really important to me. As a board certified lactation consultant, we have certain code of ethics, and we absolutely support breastfeeding. That's kind of what our job is. However, I've found that it's really important to support mom's mental health. It's important to support mom's decision making and reading a mom. If a mom gets to a point where she's tried and she's becoming so stressed out that she can't enjoy her baby, then we start to look for alternatives to kind of make it work for everybody. And there are moms that for one reason or another don't get the support early on, and then that makes them, oh, I didn't pump or put my baby to my breast, so I didn't ever make enough breast milk. That is a common thing that can happen when they don't have good support in the hospital. And in those cases, your baby is going to grow up and your baby is going to be okay. And, there's no guilt. I say, mom guilt is for the birds. Like, we start feeling guilty when we get pregnant about every little thing. And it's much better to kind of look at goals with an alternative in mind. So I always say, have your plan A. That's like your ultimate goal, everything that you want. And this should be everything from birth to how you want to parent to breastfeeding. And then you should have like an alternative. What's my B? If I have to do this, how do I do it in a way that makes me feel in control of my care? Because that's really important. I find that a lot of moms feel this is a whole other podcast, but feel very out of control in the birth process. They have things done to them, not things that they feel like are, kind of in line with like them making their own decisions. And I think I deal with that a lot actually as a lactation consultant. I'm one of the only practitioners that has really a lot of time to spend with these moms and talk through some of these issues. So yeah, it's a lot. It's always a lot, but I always say there's no guilt. It's always up to the mom, and I will always push as hard as the mom wants to push and no farther. So when moms, throw in the towel, that is a personal choice, and I support them no matter what.
What are some of the common reasons that somebody might not be able to, or decide that it's not for them, so that they know they're not alone?
Yeah. So first off, that early stimulation we talked about, where the baby gets skin to skin with mom, ideally breastfeeds in the first hour. If babies don't get that, so if a mom is separated from her baby and doesn't pretty quickly start pumping to signal the body, so that very first feed basically signals the body, the baby's not in your stomach anymore. It's time to start thinking about making milk. And so when we miss that connection, some people are more sensitive than others, and that will affect their supply. And then we kind of have to do work to build that back up. And depending on mom's health, sometimes we have a mom that loses blood after delivery and has to have a transfusion or go to the ICU. And that's a situation where mom's health is much more important than us getting her to pump her breasts. And so, those moms, we look at a picture of, okay, can we get her to do it, and does she want to, and to what extent for her health and well-being? But that's a case where sometimes later on, then down the line, it's harder to get the milk to come in because her body is just healing from that experience. Breast reduction surgery, that removes the milk making, some of the milk making ductwork and things like that. So because of that, those moms always are a special consideration. We always work with those moms pretty closely to keep babies' weights checked, to see like how much milk they're making. And most of those moms end up doing a little bit of both, a little bit of formula here and there and some breast milk. There are, on rare occasions, something called low or no glandular tissue, meaning that the mom has very underdeveloped breasts that just don't have the ductwork to make milk. It's not very common. It can be common in certain disorders and things like that. So in PCOS, for example, polycystic ovarian syndrome, some of those moms have a hard time getting pregnant, and then some of those moms can have a hard time breastfeeding. But again, none of these things are all or nothing. So you might have a mom that had a breast reduction that's rocking it, but it's always, what we consider a special consideration. So, and then sometimes other health considerations, obviously. So if a mom is not feeling well or something like that, a mom has cancer and she's on certain medications that she can't breastfeed on, those are all reasons why that could be the case.
One thing that I've noticed you've talked a lot about is the sort of timeline, and you said that they give an hour with the mom and on the chest or whatever.
Yeah.
So when the baby's born, talk about the timeline, and let's go all the way, like, how late should a child be breastfed?
Yeah.
And I know some like toddlers, maybe too old. I don't know. Is there an age too old?
So we don't really, as lactation consultants, there really isn't an age that's too old. every mom and baby, what we call couplet, is different. And, some moms choose to continue to breastfeed because their babies want to. Some moms, they enjoy the bond and continue to do it. So while there is a little bit of a stigma to it, when people are like, it's weird that like you're having them ask for it, like they're old enough to ask, at the end of the day, a lot of us feed kids cow's milk. So, we kind of stigmatize it because the mom is giving her breast, which in this country we tend to over-sexualize. So I think it's like, if you don't really think about the breast as a sexual organ, then it doesn't seem as weird. You know what I mean? So I think there really is no limit in terms of length. So for the American Academy of Pediatrics, they recommend up to a year or more, I'm sorry. And then the WHO organization, they recommend up to 2 years. So, or more, 2 years or more. I meant to always say 1 year or more, 2 years or more, but because of the benefits in terms of it's the most whole nutrition a child can get in the first 2 years of life.
Interesting. All right. One thing I remember that you talked about when you did this with my girlfriend was how breastfeeding is a natural birth control.
Yes. So now there are very important caveats to this. So, babies have to be feeding pretty much around the clock with not too much of a gap in there. But because of the hormones that are necessary for breastfeeding, it will help prevent ovulation. So many women will not ovulate, therefore they are unable to get pregnant. Where this gets dicey is if a mom chooses to give, let's say, like some formula bottles at night, or she wants to sleep a few hours, so she pumps a little extra during the day, and dad or partner is giving milk at night, and she's going long time periods between breastfeeding, then no dice on that. Then it's no longer a natural form of birth control. But there are many options and many resources out there to see exactly how to use it as a natural birth control.
All right. So this is, I don't know if it's related, but I kind of thought of it when you were talking about that. If a mom is after birth and they're breastfeeding and, they get a bacterial infection and they take an antibiotic.
Yeah. So that's a great question. We have this great resource. Dr. Hale makes a book. It comes out, I think, every 2 years that has levels of drugs in breast milk and how safe they are and what effects they have on the baby. And we use that as a reference for almost every drug that's out there. So there are very few drugs that are like no-go. Like I said, certain chemos, obviously, we can't do it. But with antibiotics, almost all antibiotics are compatible with breastfeeding. One thing I always recommend is that mom takes a probiotic at the opposite time of her antibiotic. So if she's taking the antibiotic at 8 a.m. and 8 p.m., at lunchtime, she would take her probiotic. When you take a probiotic with an antibiotic, you just kill the probiotic, so it doesn't do anything. And then I recommend having baby on on a probiotic as well. So if mom's breastfeeding and on an antibiotic, I recommend baby be on a daily probiotic, and that will help baby from getting diarrhea from mom's antibiotics. But it's still safe, even if it crosses through. It's an unpleasant side effect.
That's crazy.
Yeah.
To me, how that works. Not that it's crazy, but it's just crazy how these things.
Oh yeah,
work.
How things are transferred. Yeah, absolutely.
So when I was telling some friends that I was going to be interviewing a lactation consultant, they came up with some questions that I should ask you. Okay. And one of them said, or they asked, how can you get your baby on like a schedule?
So that's a really common question. And I will tell you, there are lots of schools of thought in the world of parenting, period, on how to parent. So I always say parenting is an art, not a science. So you're never going to get, which is very frustrating to a lot of parents, the same answer from any one person. So one pediatrician you see may say X, the next one may say Y. And you're like, I just want everyone to be on the same page. Never going to happen. So as far as that goes, most people would just say you just feed the baby on demand. It's the healthiest way to feed the baby because it takes advantage of those properties we talked about where babies learn to eat when they're hungry and not when they're not. And the rule there is when babies are little and they're trying to eat less than 8 times a day, like what little as in like
8
the
times
first.
a day?
Yes.
Wow.
Yeah. So when we're talking about, and that's on the low end, that's our minimum. There really isn't a maximum, but most newborns feed somewhere in the range of 8 to 12 times in 24 hours. With different spaces throughout that. So basically putting a baby on a schedule works really well for some babies that are breastfed and does not work well at all for others. So some of it I think has to do with personality. Some of it has to do with how much milk the baby's getting at each feed. So you kind of have to go with the flow, which is generally what you have to do when you're a parent anyway. But I feel like it's important, especially in the first 3 months, to not try too much rigid scheduling, simply because babies aren't really built for that. It's almost like they're still a fetus for the first 3 months. So we can't like box them into anything too set at that point. 3 months and beyond, often you can do a little bit more with like teaching them how to fall asleep without a nipple in their mouth so that you don't have to breastfeed them to sleep every time and things like that. But generally for the first 3 to 4 months, we kind of live on their schedule.
This might be more of an opinion-based question, but I know that the length of maternity leave in the United States is frowned upon by a lot of moms. So,
yeah.
I mean, would there be benefit to maternity leaves being mandated to be longer where the mom could feed naturally? I know, like, follow-up question kind of on top of that is, when it's pumped and put into a bottle, is anything lost?
So that's a great question. So, maternity leave, what's really interesting about right now with COVID is I have tons of moms that are returning to work, but they're returning to telework. So they're actually able to keep breastfeeding. So I'm really interested in like the impact that's going to have in the next year even, in terms of, we talk about moms missing less work when their babies are breastfeed because their babies are not sick as much and things like that. And when they're actually able to put their baby to breast, the benefits even more. So it's going to be kind of interesting to look at. So, I mean, every mom I think can benefit from more bonding time and more time with their baby. And so, yes, I mean, I think that's opinion based, and I don't know that it's a policy that will ever really change totally. But I'm kind of like, hey, if a mom has the leave, like if she has the saved up pay, I think a mom should be allowed to take the pay that she has as long as she has it. Or some people will modify FEMLA, which is the act that lets you keep your job when you're out on maternity, where they'll let a mom come back, like let's say 2 days a week, and stretch that way longer than the 12 normal weeks. So there's a lot of things out there. And different companies, when you're getting a job, look at what the company offers. Some companies offer paternity leave for dads too. And so parents will split, like mom will take her maternity and then dad will take paternity later, which will keep the child out of daycare longer, things like that. So there are kind of ways you can tweak it. But yes, I think there would be a benefit to having more time. In terms of pumping, so it's really interesting. The pump is a pretty basic motion. So the pump just takes the nipple and sort of like draws the nipple in and out, which is good for nipple stimulation. The body can learn how to make good milk for the pump. But I find that there's like things you can do to make a lot more milk, which again is kind of a sidebar, but going back to Stanford University, they have a video called Stanford Hands-On Pumping. If you Google that, that's great for any mom that's going to have to pump. Lots of good ways to get good milk there. So the freshest milk is always best. So what I tell my moms that are going back to work is what you're going to pump today, you're going to put in the fridge and give baby tomorrow. A lot of moms will talk about stockpiling, which means like, I'm going to start putting milk in the freezer so that I like have milk for the baby. So human milk is always going to be the best for a baby, but we do lose some of the immune factors and things when we like freeze it, warm it up. If we get it too warm, then we kill things off. So you think about the process of pasteurization, that's to kill everything in a cow's milk. And so it's the same idea in breast milk. So it's still going to be nutritionally the same. So your calories are the same, protein, all that stuff's the same, but the immune factors are what are going to be altered. They can be altered even by shaking a bottle. So we always ask parents to swirl versus shaking. With formula, you shake really hard. With breast milk, we swirl. Breast milk will separate, the fat will go on the top, and the less fatty milk will go down below. And so you usually have to run it under warm water to like swirl that back together. So you always kind of, the principle of freshest is best with the breast milk is a good way to think of it. So I tell moms to prepare, the stuff in the freezer is really just a couple days worth. It's for the first day you go back, and then every day after that, you'll pump and give baby what you pumped that day the next day. And I call it oops milk. So if you're at work and you spill the milk that you pumped, you have some in the freezer. Yeah. So having like 3 to 5 days of, 3 feeding bottles ready is a good like quote stockpile to have.
I saw somebody on Facebook had like probably like 40 bags
Yes.
laid out.
Yeah.
And they were asking if any new moms wanted it.
Yes.
So talk about giving it to another child.
So breast milk donation is amazing. There are a lot of moms that, you know, have a history of kids with allergies or, you know, a baby with some gut issues. And so we look at studies that show that like NICU babies, for example, that receive donor breast milk have a lot less rates of NEC, which is a condition that newborns have where their gut sort of gets infected and tries to die. And it's a very serious condition. And so we know the benefits are so there. And donor milk is completely pasteurized, like anything alive. And we're just talking about the benefit of feeding human milk to a human baby.
Is it pasteurized from being frozen somewhere, or like do they do something to it?
So they have, so CHKD here locally has a milk bank, and they will take donor milk, but they do have specifications. So it's like there has to be like certain criteria. I don't think they take milk that's like a certain number of weeks or months old. So it's always an idea if you're going to donate your milk to try to do it sooner. In terms of not a medical milk bank, there are organizations out there. There's a national Facebook page called Human Milk for Human Babies. And it's a donation system where like you would say, hey, I have 40 ounces of breast milk. Does anyone want it? And then a mom would like claim it. And then you either like meet up, they have local chapters, or anything like that. And typically, as long as mom doesn't have any bloodborne illness, so hepatitis or HIV or AIDS, the milk is very safe. There's nothing that's going to pass into it that's going to cause an issue. But you're taking that risk, taking donor milk. So it's completely up to the mom if she wants to take that risk. But donating milk is a wonderful thing that a mom can do that has extra milk.
Do they like physically look at it under a microscope the same way they would do a blood donation?
So with the milk bank, I believe that that's how they run it. They're going to check it and then pasteurize it, and then it goes into the bank. With obviously this one where it's just mom-to-mom donation, there's really no analysis. So again, it's kind of at your own risk.
Yeah. All right. Okay. So when a baby is born, you have a new patient, the mom and baby. How long are you involved with one specific mom? Is it just one consultation, like, and then they got it, or?
So that's a great question. It depends. It's so dependent because sometimes when I work in the hospital, I might look at the patient's chart and be like, oh, this is mom's third baby. And, you know, the inclination would be to assume that mom knows what she's doing. But that's really not the case. It's always case by case. So there are lots of factors that can affect. Mom may have not breastfed her first two kids. So, you know, this is brand new to her. Or sometimes mom's breast anatomy and or baby's mouth anatomy causes a breastfeeding issue that becomes something that we have to follow more long term. So it just depends. I would say in the hospital, we probably do anywhere for a mom that delivers vaginally, probably 2 to 3 visits. For a cesarean mom, maybe 3 to 4. It really depends. If the mom's trying to get out of the hospital quickly, like within 24 hours, she might only get 1. But most of the moms that go home early kind of feel very comfortable with the feeding situation. In terms of outpatient, it varies. Sometimes I have moms that just want a visit that's like, please just tell me if I'm doing this right. And that may be one visit. Then I have other moms where we have a more complicated situation or a layered situation where there's like multiple things going on. And those moms I might track for months at a time. So it really just is very case by case.
You talked about a mom having a third child and they might not have done the first 2. Is there, like, what are the statistics on somebody who didn't before and now they did? Now.
So I don't have an official statistic. I'm not a numbers gal, but I can probably find that for you. I would say that I see more and more people. So if I have a mom that had her first baby at 20 and she's 35 now, her, you know, most of the time what she'll say to me is, I tried when I was 20, but I was really stressed out. I was a first time mom, blah, blah, blah. But I really want to do it now. And that's just maturity. That's just like, I can handle life a little bit better now. Plus, after this first baby, I find that people are much calmer about all the other things that a new mom is nervous about. So new moms are nervous about like, oh, my baby made a snorting sound, or like, oh, my baby pooped 10 times today. And then a second time or third time, mom's like, yeah, that's normal. Like, oh, the baby sped up a little, that's normal. Whereas a new mom's just nervous about everything. So her breastfeeding experience is always going to be a little bit more stressful than subsequent. Usually, that's like kind of the typical thing I see.
Okay, so anybody who's an expectant mom or has just delivered, why would they benefit from contacting you or any lactation consultant? I mean, I believe you said they're assigned a lactation consultant. No?
In the hospital,
okay.
Yes. So any breastfeeding mom in most hospitals is going to see a lactation consultant. All the nurses are trained. I was a mom baby nurse that helped moms breastfeed for years and years before I became a lactation consultant. But I kind of say that I'm a troubleshooter with moms and an educator. So I do, like I said, lots of teaching. And then if anything's kind of outside of the quote norm, I'm going to address it. We're going to go over it. We're going to fix it. Mom has sore nipples, baby's losing too much weight, baby has low blood sugar, any of these things. Like, I'm going to be on top of whatever is going on. Going home is a time when I find that, like, I would say in the first 2 weeks when a lot of issues arise. And if your pediatrician's office doesn't have a lactation consultant and you're just kind of out there in the world trying to figure it out, I find that that's a time when moms will either give up or make a mistake. For example, when the milk comes in, if a mom gets engorged, which means she gets swelling in her breast, it's harder for baby to latch because everything's tight like an overfilled balloon. And mom will get sore nipples and baby won't be transferring well. And they'll end up, literally, mom has milk in her breasts, but they'll end up giving formula because they just don't know what to do. And if they had someone to ask this question to, hey, my breasts are really firm and hard, what do I do about this? And if you don't know breastfeeding terminology, you wouldn't even know what to Google necessarily. Like, you might not be like, how to treat engorgement. Like, you might never heard the word engorgement before. So we do send moms home in the hospital with resources like a book and things like that. But again, I find that a lot of moms just need that backup support. And so I think it's worth it. I think especially now that, again, more of us are trying to take insurance, this is like hopefully like a not out of pocket expense for you. And I think a lot of moms are feeling good about that when they realize, like, oh, I don't have to pay for it. It feels a lot different when you're shelling out $250 versus $0.
All right, we'll start wrapping out because I know you got to run out. But my next question has to do with you having to go. So you are going after this. I don't know anything about the patient because obviously privacy, but you're going now to Richmond.
Yes.
What are you going to do for this person?
So my area, if you will, is Hampton Roads typically, but I was headed to Richmond actually for some film stuff this weekend anyway, and I got a referral for a mom who was going to just have a telehealth visit with me. So I just reached out to her and I said, hey, listen, like, I know you signed up for telehealth, but I'm actually going to be in your area. Would you like a visit at home? And so we arranged a home. So every mom and baby combo is different. This baby's a couple months old and just needs some help with breastfeeding, basically. So, it's kind of like new things pop up. And I do get a fair amount outpatient where, like, baby's 8 weeks, 10 weeks, 12 weeks old. So it's like things were going well and then there's a misstep. So it's usually like right after birth or a couple months in that sometimes something can pop up.
So with your company, you're going to do home and telehealth.
So I'll do home and telehealth. And then one of my goals, and so if anyone listening wants to help me get a Medicaid number, is to serve underserved populations. Right now, there's very few lactation consultants that accept Medicaid, and that's like really a goal of mine. I really want to accept Medicaid because there's a large population of moms that when they're leaving the hospital, I feel like they need help and I don't know where to send them. WIC has some good programs for sure, so I will refer them there. But I really want to be able to serve every mom, and that's really important to me. So my sister-in-law runs a addiction clinic in Richmond, and I would love to take on some of her patients that are interested in breastfeeding, just to give them as much chance for success as possible.
In the interim, until you can accept that, how hard is it to let somebody go and knowing you can't do anything beyond what's in the hospital?
It's pretty tough. There are a couple companies that do like online type visits, not in home, but online things that will take Medicaid. And so I'll try to refer them to either WIC or those resources. And I mean, very honestly, there have been times when I'll like email back and forth. I also run a mom-to-mom support group through the hospital. So I'll be like, log on to Zoom, like, let's talk through this on Monday. I try to run that once a week. So I definitely try to make sure that they have as many resources as I can offer them. And I will often spend time on the phone, like calling around to find her help if she needs it.
Going the extra mile. Where can people find you for, if they want to see your art, your filmmaking, and more, importantly to this conversation, your company?
So my company is called For All Momkind. I want it to feel very inclusive. I want everyone to feel like they're welcome and can ask questions. I don't ever want a mom to feel like they failed at anything, and my goal is to always lift mom and the families up. And so that's kind of where the name came from. So I do have a website that is forallmomkind.org. So that is where people can go to get a little bit more information about kind of what we're doing.
Cool. Well, thank you for talking to me. I definitely, again, am the dumbest in the room, but I feel like I learned a lot.
Good.
And one day, if I can hopefully have a kid, I'll know what to do.
You'll know who to call.
Oh, I mean, Ashley will know because she's a nurse, but I'm sure she'll still.
Yeah, I think you always have a lot of questions, even when you're a medical person. A lot of my patients are medical people, so it's very different when it's your baby.
Yeah. Well, great. Well, thanks again for coming, and go help that patient.
Yes, thanks so much. Have a good day.